Oh, I know. Good afternoon, everyone. I'm Leah Hollins, the chair of the Board of Directors of Island Health. On behalf of my colleagues, welcome to the public forum. I acknowledge we are on the shared, unceded traditional territories of the Lee-Wah-Taw people, the Wee-Wah-Kum, the Wee-Wah-Kai, and the Queequaw. I acknowledge with respect and gratitude that Island Health provides care on the lands of the Coast Salish, New Chelmsford, and Kwakwaka'wakw cultural families. We also recognize the Métis, Inuit, and other Indigenous peoples across Canada. We do this to reaffirm our commitment and responsibility to improving relationships between nations and to cultivating our own understanding of Indigenous peoples and cultures. Please join me in reflecting on the harms done to Indigenous peoples, such as the cultural genocide and assimilation of Indigenous peoples, the residential school system, and the discovery of graves of Indigenous children, the 60s scoop, the too many missing and murdered Indigenous women and children, and the social inequalities and prejudices that exist today. I invite you to think about the responsibility we each have to act in a spirit of reconciliation, healing, and collaboration. Public forums provide an opportunity for the board to meet the people and communities we serve and are an important part of our commitment to transparency and accessibility. I'm hoping our time together will help us to understand what matters the most to you, so we can increase our understanding and refine our thinking. As a governance board, we are responsible for the overall direction of Island Health. The reason we are appointed by the minister to sit on the board is because we care deeply. As a former nurse, a deputy minister, and chair of Canadian Blood Services, one thing that's always been central to my work is the patient. I always ask myself, is what we are doing right for the patient? Because caring for the patient is why I started working in healthcare and why I continue to support the delivery of health and care. Caring is also why every member of the Island Health family are dedicated to delivering Island Health's vision of delivering excellent health and care for everyone, everywhere, every time. It's now my pleasure to introduce you to our directors who are responsible for the overall direction of Island Health. The board consists of 10 directors appointed by the Minister of Health. In addition to me as the chair, the board includes Vivian Hermanson from Campbell River and our newest appointee to the board, Shawnee Cassavant from Hopuchesset and Sayshot First Nations on the West Coast, Diane Brennan from Nanaimo, Ann Davis from the Comox Valley, Ron Matson from View Royal, Ann McFarland from Victoria, and Ron Rice, a member of the Cowichan tribes who lives in Victoria. We have 2 members missing today, Alana Nast and W.J. Whitemarsh from Sydney. We also have members of our local leadership team and our executive management team joining us this afternoon, and I'll ask them all to stand and give us a wave. You'll hear from some of them this afternoon. Hey, folks, let's see who you are. Great, thanks very much. Our meeting begins with a short video about Island Health and some of the services we provide.
Serving 875,000 people, Island Health's focus is the health and wellness of the residents and communities on Vancouver Island and in surrounding coastal communities. Our diverse geography spans 48 settler communities and 50 First Nations, from Alert Bay to Victoria, from Tofino to Comox. We acknowledge with respect and gratitude our privilege to provide care services on the traditional unceded territories of the Coast Salish, the Kwakawak, and the Nuu-chah-nulth cultural families. The Island Health family includes 27,000 healthcare professionals and 1,000 dedicated volunteers. 2,900 doctors, nurse practitioners, midwives, and dentists make up our medical staff. We provide health and care services at 145 facilities, with more than 6,600 long-term care beds, nearly 1,400 mental health and substance use beds, and more than 1,800 acute care and rehabilitation beds. Island Health has an annual budget of $3 billion. Each year, this funding supports 491,000 visits to emergency departments, more than 73,000 surgeries, 59,000 MRIs, 152,000 CT scans, 2,100 telehealth visits, more than 51,000 visits to urgent and primary care centers, over 16,000 home health monitoring visits, and 463,000 home health care visits a year. Island Health has expanded our primary care services with 5 Island Health urgent and primary care centers and 7 patient care networks operating across our region, with further expansions in the works. Under the leadership of 6 medical health officers, Island Health works to promote health, prevent disease, and improve quality of life. Each year, we conduct more than 2,000 inspections of childcare facilities, 600 inspections of licensed care facilities, and 4,500 inspections of food service operations. Public health nurses provide more than 5,000 perinatal home care visits, and in partnership with FNHA and community pharmacies, more than 2 million COVID vaccines have been provided in Island Health. From before birth to end of life, Island Health strives to provide excellent health and care for everyone, everywhere, every time.
So that's a great way to start our program today, and we have a full program. Island Health's President and CEO, Cathy MacNeil, will begin by providing an update on the delivery of health and care services across Vancouver Island and here in the region. Dr. Charmaine Enns, Medical Health Officer for the North Island, will speak about public health and wellness in Campbell River. We'll then have a presentation on a collaborative multidisciplinary care team who support people in Campbell River who are marginalized and at high risk by partnering up services from public health, mental health, substance use, and primary care outreach. The last part of the agenda will be an opportunity for you, community members who have come to our meeting, to ask questions so that the board can hear from you. For the first time, we are also live streaming this in-person meeting. The first one we've been able to have since the pandemic changed so much for all of us. We hope to take the learnings of our community engagements during the pandemic, which were limited to only being online, and combining them with this in-person forum. We ask that you send in your questions in advance by email, and only so many of those questions are possible, and we will try to address as many as we can following the presentations and in the question and answer period. So I'll now invite Kathy MacNeil, Island Health's President and CEO, to open with an update.
Thank you, Leah, and good afternoon, everyone. I too would like to express my gratitude to the Lake-Wita people who have welcomed us to do our business on their lands here today. And we know Indigenous people's relationship to the lands is of critical importance to health and wellness. We also honor their customs and traditions as we continue to do our work towards creating a culturally safe healthcare system with respect and humility. As Leah said today, I'm delighted that we can finally gather together in person. We're a little bit rusty. We've been doing a lot of this online, but it's really good to see people and be in the same room together. Everyone in this room plays a role in helping us work towards our vision of excellent health and care for everyone, everywhere, every time. There have been some areas where we've been able to advance our goals faster if it hadn't been for the pandemic. It created a bit of a silver lining in that regard. First, we learned new ways of working together. Partnerships have been formed and strengthened over the past 2 years that have been extraordinary. Our partnerships with First Nations communities and the First Nations Health Authority led government to change the sequencing of vaccine rollout to ensure that Indigenous peoples were clearly supported amongst the highest populations at risk. The pandemic required us to build bridges with local governments, with primary care providers and others, disrupting traditional patterns and moving in new ways. We've also experienced significant challenges. Front and center is the sustainability of our people, our workforce. Our major focus going forward is on the people who care for people. I look forward to sharing some of the work that we have underway island-wide and here in Campbell River. As a health and care provider, we face a dual challenge of meeting today's needs while also planning and preparing for the future. I'm going to talk a little bit about our longer-term vision and the work ahead of us in the coming year to help us achieve that vision. At the very beginning of 2020, that seems forever ago, we launched our strategic framework, laying out our destination for the next 5 years. Little did we know at that time what was about to hit us over the next 2 years. Now we're taking some space before mounting a response to whatever comes next, to look closely at our strategic framework and incorporate lessons learned during the pandemic. We know we're on the right track while we're working hard to continue to advance our long-term goals. We know we have lots more to do. We've identified 8 organizational priorities for this year: cultural safety and humility, access to priority services, safety and practice standards, staff safety and wellness culture, health human resource sustainability, innovation and ensuring we have right care at the right place, the COVID ongoing response and recovery from that response, as well as the climate change work that we need to do, and addressing the ongoing drug toxicity crisis. As you can see, we have a lot of ground to cover. I'm going to touch briefly on 2 areas. First, as I mentioned a moment ago, is our health human resources work. Our people are tired. 2 years of pandemic response, on top of pre-existing staffing and structural challenges, have been enormously taxing for them. In response, late last year, we launched our health human resources sustainability work. We are pursuing multiple strategies to improve the day-to-day work environment for staff and medical staff. This work is a key organizational priority for the next year and beyond. If our people don't feel healthy and supported, they can't help you be healthy and supported. We have a dedicated team plus people at all levels of the organization prioritizing this work in 5 key areas. Embracing flexible work. We have heard from our workforce how important it is for us to build flexibility into how we do health and care so that they can have some balance in their lives. Developing great leadership. Creating ways for people who move in different ways throughout the healthcare system. Flexible and adaptive care models. And finally, we need to get to a 21st century competitive talent program. Everyone is looking for staff. We need to be able to compete with the world. One example I want to highlight is the Health Career Access Program. You may hear of that referred to as HCAP. This program provides an opportunity for people to come to work for us in a non-direct care role while getting trained to become a healthcare assistant. They get paid for that work while they're training. We have hired 65 home care graduates from this program, 4 of them here in Campbell River, to care for people in their homes. Another example of thinking differently is how we use the people we have. We developed a low acuity unit at Campbell River Hospital staffed with providers who can meet the needs of patients who don't require as high a level of care as other patients. This allows us to provide the right level of care for those patients while freeing up our more highly trained nurses for patients who need the more acute level of care that we need that expertise for. The HR challenges are significant, and just as it's taken years to get to where we are, it's going to take us some time to resolve them. We are committed to our people, and we're putting resources towards this important work, which often requires us to change our mindsets and our traditional ways of thinking. Which leads me to the other key priority I want to share with you today. Right care, right place. Right care, right place is about the way we provide care for our community and our commitment to continuing to innovate that care. It's about the possibilities that exist for multiple levels and locations, including optimizing care at home. If we can ensure patients have access to care in alternate locations other than hospital beds by investing in community, we can make our hospitals more functional and ensure we're providing the most appropriate care. We're doing that in a number of ways. We've implemented a home intravenous program where some people can receive IV therapy in the comfort of their own home rather than having to come and stay in hospital. We've increased home support visits. You just saw on the video. In 2018, we supported just over 500 clients here in Campbell River with about 120,000 home support hours. Last year, that was up to more than 155,000 hours and more than 600 clients. We've developed relationships with businesses such as hotels, cleaning companies, couriers, pet sitters, and contractors to help support people who need those services to enable them to discharge home. We've created an enhanced discharge team to support complex discharges from hospital and ease the transition back to home, to assisted living, or to long-term care. We're hiring a respiratory therapist to provide support and community to people living with respiratory illnesses such as COPD. And Community Health Services has developed a process in partnership with Public Health to support flu and COVID-19 vaccinations for those homebound patients who find it difficult to get out and about. A community of care that takes place beyond the walls of a hospital, including inside people's homes, requires new ways of thinking. Right care, right place requires us to break down our silos, work together, and do things differently. This also means finding innovative new ways to provide care. The pandemic accelerated our ability to innovate. Overnight, we moved to virtual care, using call centers in different ways, and actually delivering acute care using a hospital-at-home program. Island Health is working closely in partnership with area First Nations and the Division of Family Practice to develop a primary care network service plan to support approximately 8,000 area residents who are not attached to a primary care provider. 2 new nurse practitioner positions have already been initiated from the draft plan. One of those nurse practitioners is located at North Island Medical Clinic to provide primary care to an extremely vulnerable population there, while the other is working out of the Bridge Clinic in Oyster River, a rural clinic that lost their physician to retirement. Primary care COVID funding also allowed our mental health and substance use team to hire providers for outreach primary care and opioid agonist therapy services to vulnerable populations. I think we're going to hear a little bit more about that work, and I'm very much looking forward to learning from Leanne and Elizabeth. We so clearly saw through our pandemic experience the impact on underserved populations. While COVID touched the majority of the population as a whole, it had an incredible and disproportionate impact on people who were underserved and underhoused. Cracks that were already in the health system for underserved people were clearly exposed and exacerbated. While we have work to do here, there is work currently being done. Our partnership with the Vancouver Island Mental Health Society is providing overdose prevention services for those in the Campbell River area who need it most. We created a new addiction medicine consult service where a physician and a nurse partner to support patients and families. And we hired a mental health substance use consult liaison nurse to support patients who are admitted to hospital with their mental health concerns. In 2021, in collaboration with the Community Action Team, a peer support role was created to support patients with substance use concerns. People with substance use disorders report feeling more comfortable presenting to the Campbell River Hospital Emergency Department since this position was implemented. We hear time and time again that the antidote for addiction is connection. It is part of the healing process to create these supportive connections, and no one is better positioned to do that than people who have walked the road. Also last year, we collaborated with the Walk With Me project and supported over 200 Campbell River Hospital and community staff to participate in audio walking tours to experience through the voices of those impacted by the drug toxicity crisis and imagine new ways to move forward, free from stigma and judgment. And I don't know if all of you or any of you have had an opportunity to participate in the Walk With Me project. I did it one rainy night in Comox Valley, and it certainly has opened my eyes to the experiences of those who are living on the streets in the cold and dark rain, and listening to their voices and changed some of my preconceived ideas. Earlier today, I was able to join our board of directors and many of our community partners in a conversation about the future and what's possible when we work together. We talked about our proposal to build a new 153-bed long-term care home next to the Campbell River Hospital. If approved, these net new beds provide seniors and elders high-quality care close to home, while also reducing the numbers of people waiting in hospital for long-term care placement. I'm so grateful to the Comox Strathcona Regional Hospital District for agreeing to partner with us and the provincial government when we are able to move this project forward. It says should here, but I'm just going to say when, because I think Charlie Cornfield would make sure that we said that in this room. I also want to thank the Strathcona Regional District and the Campbell River Hospital Foundation. They're working together to build and operate a Just Like Home Lodge on a piece of land set aside for them next to the hospital. This lodge will be a home away from home for patients and loved ones needing to travel to Campbell River for specialized medical care or procedures not available in their home communities. The lodge will be right next to Kwailayu House a home away from home for children and their families receiving treatment here. The last time our board of directors gathered here in Campbell River in 2019, Quilayu House was just a dream. Now they are approaching their first anniversary of their opening. It was so wonderful to go inside and see it in person for the first time this morning. I just want to take a few moments as we close to talk about something that's vitally important to me, to our board of directors, and to our entire organization. Prior to COVID, we spoke of the importance of cultural safety and humility. Today, we are saying something more. There is racism in our health system. There's Indigenous-specific racism inside Island Health. It's not acceptable, and we must address it as leaders. And we are taking steps to address it. While there's much more to do, I want to talk about some of the great work that's already been happening here. Unfortunately, Cheryl Thompson, the elder in residence at Campbell River Hospital, is not well today. She was going to join us, and she was going to have some time with our board to tell them what it's like to be our first elder in residence. It's unfortunate that she wasn't able to join us. I was so looking forward to meeting her and hearing about her experience. But I do know what we hear back from Indigenous families, patients, and those care teams who work with Indigenous patients, that her presence changes the experience of care, and it changes the cultural safety for those who receive care, because she promotes understanding and respect for the Indigenous knowledge, culture, practices, and values. This region has implemented a Triad leadership model where the area medical director, Michelle Crosby, who's here, the executive medical director, Dr. Dieter DeBrun, who is here as well, and the Indigenous health director, or manager, sorry, Michelle McLean, who's not here, but we are joined by Mary Knox, who's the Indigenous health director. Those three leaders, Dieter, Michelle, and Michelle, work together to ensure provider and Indigenous voices play a role in all operational decisions. The Campbell River Hospital site director, Tricia Sinclair, and managers at the hospital have created relationships with local Indigenous health leadership to work in partnership on initiatives at the hospital. One recent example was a staff engagement event celebrating local Indigenous language and traditional foods, which also incorporated drumming and dancing. We will continue working in partnership with area First Nations and Indigenous organizations to ensure the services we provide are delivered in a culturally safe and respectful manner, so Indigenous patients and their families always feel welcomed, heard, and supported. Our vision and values continue to be our guiding force through the difficulties that we face. We returned to them again and again during COVID, especially when we were in times of uncertainty and we didn't have a clear roadmap. Returning to the basics, our vision of excellent health and care for everyone, everywhere, every time, got us through and will continue to serve us. The only way ahead in achieving those results is one that we walk together across silos and departments, across organizations, across communities, because we're all in service to the people who need us. Before I close, I do want to acknowledge and send appreciation to the people who are at the hospital, in the community, in programs today, working very, very hard to ensure that the people that they see have that high quality care. I just wanted to share a story because I like to tell stories, first of all. But secondly, I had an opportunity to meet one of those people today. I met Anne, who is a new pharmacist. She moved to Campbell River with her partner, who is a family medicine resident, so I'll come back to that in a minute. And Anne moved here from Ontario in October. And so I asked her, what's her experience been like moving here to Campbell River, and in particular working at the hospital? And she said, it is awesome in this community. The people are so kind. They're so hospitable. And I had concerns about coming to a small hospital in a small area because I did my training in a large urban center, and I just didn't know if the standards would be the same. And she said, what I'm really pleased by is the high quality of care that's delivered here in Campbell River. And I just wanted to share that with you because we don't have to have all the bells and whistles that might be in downtown Toronto to be able to deliver high quality health care. We need people like Anne to believe in it and to be able to tell that to colleagues when things are tough. I did ask her if her partner's staying here, and good news is yes, he is. So you'll have another primary care provider soon. I want to thank you for being here today. I know it's the day before a long weekend, and just your presence tells us that we have people who are along with us on this journey of improving health and care. Our mission is of ensuring all Vancouver Islanders have that excellent health and care is one I know that you share with us. So thank you, Gayla Kesla.
Thank you, Kathy. You know, it takes a lot of people in leadership to make sure that the ship runs well. Thank you. So now I'm pleased to have one of Island Health's medical health officers, Dr. Charmaine Enns, here today to provide an update for health services in Campbell River. So the board had the opportunity to spend some time with Charmaine about a month ago, maybe not quite a month ago, and you'll see what I mean when I say that it was fabulous.
Oh,
So,
thank you,
you.
Leah. So hi everyone, and my name is Charmaine Enns. I'm your public health doctor for the North Island, and I have been your public health doctor for just had 19 years as my anniversary. So, yep, I'm still here. I love the North Island, what can I say? And I also want to recognize that I've got the tough gig time. This is the time when everybody falls asleep from lunch. So I'm going to try to make this interesting. It's not about health services, this is about health status. So just want to say, Leah, that we're going to talk about the health of the population. So I only have a few minutes, so I'm going to go through this kind of quick, because that will hopefully help keep you all awake and with me. Okay, so we're going to talk about Greater Campbell River, and we have broken down the local health areas to smaller community levels now, called community health service areas. This is just our ability to collect data and report on population numbers within a defined area. So I'm going to talk about the community health services area that include Campbell River and Campbell River Rural, the big area. Next slide, please. And so you can see on the map, that's actually a pretty big geography when you include the rural. So for the Campbell River, the smaller one, 4321, so that's the city of Campbell River. That's Wewakam, Wewakai, Queka, and Homolko. And then that's a population of about 37,500 people. And then the larger rural population of just under 10,000 is the rural population. So I'm going to mainly talk about those combined, but also there's some that's separate. Next, please. So when we look at the population demographics going forward in time, I don't know about you, but I can't see those numbers. But if you can just see that the blue is the over 70 plus population, and the demographic, the significant increase in the proportion of the population that's older. So as we go forward in time, there's going to be more people over 65 and 70, and a significant number when you look at it from proportions. The absolute numbers are not as high, but proportionately it gets higher and higher. And that makes a difference for us to understand these demographics as we do planning and program planning and just understanding the needs of our population. You can also see, though, that the other age cohorts are also increasing. And the one on the left is the Campbell River urban, and the one on the right is rural. And you can, I really love to see how the populations are going up in the rural areas as well. Next, please. So something that's not specific to Campbell River, but it's all of our reality is climate change and what it means for us as we are now going to have to continue to adapt and live with extreme weather events all the time. So this is broken down some data for North, Central, South Vancouver Island related to the heat dome, that week of extreme heat last summer. And on the far left is the proportion in numbers of people who died from the heat dome in South Island. The middle is Central. Central had the highest rates of impact. And then on the far right is the North Island. So there was a total of about 48 deaths related to that heat dome in that week on Vancouver Island, and I believe the number's 8 for the North Island. So why do I put this up? Even though the numbers are small, it's about the reality that we are going to have to deal with heat events, and they're going to be members of our populations that are going to be more at risk than others from those events. And so this is just one example from last year's heat dome. Next slide, please. And this is what happened on Vancouver Island in regards to our drought ratings. And this is all, again, over a matter of 3 weeks or so. The significant change in drought levels as we went from the middle of July to the middle of August. So you can see on the east side of the island, they were experiencing more drought than the rest of the island, but the whole island was impacted. So the darker the color, the higher the drought level. And by middle of August, we were in extreme drought. So why is this important? Well, we need water. We need water for consumption. We need water to grow crops. We need water. Water is life. And then we have the risks from wildfire, urban interface fires, and then, of course, there's the human health impacts, and then what it does to our ecosystems, et cetera. So, again, another example of climate change and how fast it can change, weather events can change and impact us in our communities. Next slide, please. So now I'm going to switch gears completely, but talk about the top causes of death in age groups on Vancouver Island. And this is a busy slide, but there's really one piece of information, most important from my perspective, that I'd like you to leave with today. And that's when you look at those age cohorts, that for those that drug toxicity deaths are in the top 2 leading causes of death for ages up to the age of 60. So for people under 19, it's the second leading cause of death. For people between 19 and 39, it is the top leading cause of death. For people between 40 and 59 years of age, drug toxicity is the second leading cause of death. I hope that impacts you, because that is something that is not out of our ability to influence. These are people in the prime of their life where drug toxic events are killing them. So I can't emphasize that enough, because the pandemic has made this situation far worse. It's isolated people, we have a more toxic drug supply, and we really have to do something about it collectively, all of us. So I just wanted to raise this as background for the next slide, please. So when we look at illicit drug toxicity deaths for the greater Campbell River area, and which is represented in the blue graph line, and to all of the rest of Vancouver Island, which is in the mustard color, you can see that the rate of drug toxicity deaths is about 40 to 50% higher. So Campbell River has the highest rate of drug toxicity deaths on Vancouver Island. Next slide, please. And then when we break it down, when we look at their, for that population in Campbell River that have had a death from drug toxicity, which is the pointy end of the problem. So death is an ultimate outcome, and then there's a whole population of people impacted below that where they haven't had a fatal outcome, right? So we're talking about thousands and thousands of people in our community in Campbell River area, thousands. So when you look at the rate per 100,000, the highest impacted age group is 25 to 44 years of age. Second to 45 to 64. You want me to go faster? Blah, blah, blah. Okay. Then we have, when you look at the breakdown by sex, the rate's the highest in men, and that's on the other side, which is the green is men and female below that. Next, please. So we do have overdose prevention sites and opioid agonist treatments. Just to highlight, I just want you to see especially the top graph, which is visits to the opioid overdose prevention site. The overdose prevention site gets over 1,000 visits per month. This is a significant intervention for saving lives and connecting to services and other interventions. The bottom is just for opioid agonist treatment, and approximately 400 people per month in Campbell River are on opioid agonist treatment, which is a substitution from using illicit drugs. Next slide, please. So there's a prescribed safe supply, which is this exciting new program for Campbell River, Comox Valley, and Mount Waddington in the north part of the island. AIDS Vancouver Island has received a grant for $2.8 million from the Health Canada to provide a prescribed safe supply program. It sounds like a lot of money, but that only actually provides an intervention for 30 individuals in each of the Comox Valley, Campbell River, and the north part of the island. This is a physician or nurse practitioner prescribed program, and people become into this system and have significant wraparound services and care. So it's got multiple service providers and multiple supports, which everybody actually should have an opportunity for. But this is starting in the North Island, and I'm very excited about it. I'm a strong supporter of the prescribed safe supply. And it will actually help stabilize people's lives. And it will keep the toxic drug supply out of their system. Next slide, please. The SPEAK survey, which is, I'm on to a new topic now. Throughout the pandemic, we all have a story. The population has a story, families have a story, communities have a story, individuals have a story. So how do we collect what's happened to people? And we do that through surveys, for example. So we can get, it's in public health, this is one of our diagnostic tools. So taking away our ability to survey a population or to get population level data is like taking away from the eMERGE doc an X-ray or blood work. So for us, the SPEAK survey is has been a really important way to understand the impact of the pandemic on populations as time has gone on. So there was the first one done in 2021, in the spring of 21, last year in the spring of 2022, and we're ready to launch, the provinces through BC-CDC, we're ready to do the SPEAK Survey 3. We're just waiting for the go-ahead from the province to be able to launch SPEAK Survey 3. This has very specific community data, information, which will make a difference for local governments, for NGOs, for agencies and other service providers, in terms of their program planning too, because we have collectively a lot of work to do with recovery as we come out of the pandemic, and especially when we understand that many of our interventions, while unintended, have caused a significant amount of harm and put people back in their life somehow. So next slide, please. So when we look at health and wellness in the Greater Campbell River local health area, so this is urban and rural, this is just to show that the top line, which is green, which is mental health, mood and anxiety disorders, is the leading cause of, is the leading diagnosis for people accessing care in the Campbell River area. And when you, on the bottom bullets, those buttons are looking at what's happened in terms of what people have reported for mental health and stress from the first SPEAK survey in 2020 to the second SPEAK survey in 2021, and mental health and wellness has deteriorated as the pandemic has gone on. Next slide, please. And this one is just to show specifically for youth. So for kids 1 to 19, there's green, there's the mood and anxiety. And I realize, again, all populations and all people have been impacted in the pandemic. I especially want to do a call out for kids, because children have been disproportionately impacted in the interventions and what disruption has resulted in their life through the pandemic. And it is so important that we recognize the needs of kids and young families, that we get them socializing again, connected again, having fun, playing, learning, being adventurous, curious, those things that kids really need: social development, language, how to cope, how to interact with each other. So I can't say enough about kids, and what is very important too from the Speak survey is that based on parents' response to the Speak survey, over 90% of kids are dealing with stress and mental health issues as a result of the pandemic. Next slide, please. So when you look at Campbell River residents and what they want to see changed as a result of the Speak survey, and when we look at the city of Campbell River, and those other communities are on the left and rural is on the right, there's five domains for each, and they overlap for three, the rural and the urban. And they overlap for improve access to health services, reduce income inequality, and work flexibility. Everybody wants that. The urban center was had a special interest to increase funding for science and to, why didn't I bring my paper with me? Create more parks, which you don't need to do if you live rural because you already have your park. So then rural, there was about the climate change mitigation, really that we invest in that. And what was the other one? Improve infrastructure. Thank you, Kathy. So while there's similarities, there are also differences, and that's really important. As of course, as we work in our communities, that we make change based on what people are. We intervene where people are saying they're ready and willing to see that change. Next slide, please. And that's it. And thank you for staying awake. I really appreciate that.
I frankly can't imagine anyone falling asleep when you're speaking, Charmaine. That was terrific. Thank you so much. And now we have a special presentation on how our integrated multidisciplinary teams, my favorite words, are supporting marginalized and at high-risk people. Board members will have an opportunity to ask questions following this presentation. And I just remind you that when you speak, you have to hold the mic up quite close. So let me welcome Leanne Combe and Elizabeth Driver from Island Health's Mental Health and Substance Use team. We are really delighted to have you.
Hello, and thank you for this opportunity to speak to you today. My name is Leanne Combe, and I am privileged to be the manager for the Community Mental Health and Substance Use Services for Campbell River and Comox Valley. I'm honored to be in my role, and I'm proud of all the work MHSU teams do to support people accessing our services. When I started this role in 2020, I wanted to understand where the gaps are in supporting people experiencing homelessness as well as substance use disorder and mental health struggles. In the midst of COVID, I was able to meet with several community partners, including RCMP and the Downtown Business Association, as well as hear feedback from those who access our services and their families regarding what was needed for outreach in this community. This helped shape the vision of our substance use integrated team. We creatively combined a couple of smaller teams to create one larger team, now known as SUIT. We have had great success in working together with RCMP, public health, primary care physicians, multiple community partners, and with those who utilize our low-barrier accessible team for many of their healthcare needs. Elizabeth Driver, the clinical coordinator for outreach services, is here with me today and will share more about the SUIT team. It is with great pleasure I'm going to pass things over to her, and I'm grateful for Elizabeth and her team's passion for the work that we do and for the deep understanding they hold for what meeting people where they're at actually looks like in action. Elizabeth?
Thank you, Leanne. It's my pleasure to be here today. And before I start my presentation around the Substance Use Integrated Team, I wanted to take a moment and say that I was listening to Kathy MacNeil's speech about the experience of what it's like to come to Campbell River. and I'm so pleased to see so many people here today for this important discussion. I started in Campbell River after many years of working in Nanaimo, and I just find Campbell River as a whole community is a wonderful place. It's such a small community, and I find even at the crosswalks, people are like, no, no, you go. It's friendly, and the connections, people, yes, please. People really come together, and I've just appreciated so much the opportunity to be here today to highlight the work of the SUIT team. Thank you. SUIT was formed in 2021. We have 11 team made up of nurses, clinicians, addiction recovery workers, and an Indigenous liaison, and also a peer support worker. SUIT is a mobile outreach team whose focus is working with people who struggle with homelessness, addiction, isolation, poverty, food insecurity, and complex mental and physical health concerns. They work with people on an as-needed basis, but they can also work with up to 25 people who require intensive ongoing supports for addictions and complex care on a case-managed basis. The goal with SUIT is to build relationships and assist people in accessing healthcare and other services, such as primary care, medications, wound care, public health support, such as pre- and postnatal care, referrals to withdrawal management and treatment, housing referrals, and provide harm reduction supplies. One of SUIT's primary focuses is on overdose prevention. They will follow up with people who have been in hospital as a result of an overdose within 72 hours. They also follow up at many of our community service partners, such as AVI, the Evergreen Homeless Shelter, the Overdose Prevention Site, the Sobering and Assessment Beds. They make daily trips to ER, and they check in with our supportive recovery services and housing services. The team wears orange coats. You can see one in the audience here. Thank you, Tom. They are highly visible. They roam up to 5 kilometers at a time. I heard one of the staff remark one day they put 14,000 steps on their step counter after a day of roaming. And you can see in the slide there, the snow out behind them. They are on 365 days a year in every kind of weather. One very successful connection is the work with public health. We have a public health nurse who roams with the team twice per week. The team is thrilled to have this connection. People are able to receive public health supports out in the community where they are, when in many instances they might not be able to access this important service. This collaboration results in reduced fragmentation between services, enhanced communication between teams, and leads to improved patient outcomes. Next slide, please. Our primary care outreach collaboration. Working with the primary care outreach team is a successful partnership. The primary care team joins in on case reviews with SUIT each week, and the primary care outreach physician actually roams with the team on Wednesdays. This helps prevent hospitalizations. Patients are able to receive primary care out in the community. People have faster access to assessments, medications, and treatments. Our Indigenous liaison summed up her experience of working with our primary care team member on an outreach day. We worked with a young woman who was interested in cutting down her drinking. The doctor so carefully listened to her story and took time to explain all of the different treatments. That young woman was cared for and respected and treated like a human being. It was one of my best days on outreach. This on-site care meets the needs of clients who would not or could not access conventional healthcare services and locations. It is a perfect match to meet people where they are at and provide services to vulnerable people. Our staff went on to say, I am proud of my team. I am proud of the people who trust us and know that we are working with them. I am proud of my Indigenous brothers and sisters who will allow us to be part of their lives. I am proud to work in healthcare. My wish is that we have seamless healthcare for all. My wish is that we have all people have access to compassionate and non-judgmental health care. These are amazing collaborations, and as our team lead, Tom, in the orange coat, summed it up, it is hard to imagine the impact of not having this collaboration available to our clients and community partners. Next slide. Recently, the team was invited to visit one of the local high schools to provide education and mentoring in the community. 3 of the team members went out to provide naloxone training and information to students about how to get into careers in mental health and addiction work. The team spoke with over 120 students and 7 teachers. Over 120 people were trained that day on using naloxone kits. The feedback was overwhelmingly positive. Students were pulling the team out, aside and asking how to get into mental health and addiction work, and they were thankful for the training. The teachers were hoping the team could come back to provide more of these sessions. Our staff had commented afterwards, "I am hopeful our team can offer more regular education. I'm so grateful for this partnership." Next slide. A question I'm often asked is, what does the SUIT team actually do? I went out roaming with the team to see for myself, and I can tell you, after almost 30 years of community nursing, this is different work than I've ever done. So imagine walking about town. How do you approach people, especially if they don't invite you over? And they might be wary of healthcare providers or strangers. It takes time to build trust with people who might be wary of strangers. While out roaming, I saw care happening in such unique ways. Sometimes people just waved us over and said, "Hey, come on over here." And the team would go over and people would share their stories. What easier way is there to access healthcare? I learned that day that care happens when we are building relationships. Care happens when we are collaborating with all of our community service partners, including the RCMP, the EHS, emergency room, primary care outreach, our public health team, the Overdose Prevention site, and the Indigenous service partners. There are so many caring and passionate people working together to support our community. Next slide. I spent time reflecting on the work that we do while preparing this presentation this last week. Sadly, I had to spend time hugging a mother who watched as her son came off life support and passed away. And then in the very same day, SUIT was roaming out at one of the local parks, handing out water, sunscreen, harm reduction supplies. And someone called in an isolated corner of the park and said, "Hey, we need help over here." Someone had overdosed, and 2 of the team arrived on the scene and working together provided multiple doses of naloxone, supported rescue breathing, they called EHS, and provided CPR on site. They saved this person's life and revived them while waiting for EHS. It is these stories of both grief and success that strengthen my resolve and my commitment for my work. I am grateful for the opportunity to be here today to highlight the substance use integrated team.
Thank you, Elizabeth and Leanne. That was really excellent. And somehow, thank you doesn't just quite do it. We really appreciate the work you do. It's not easy, but thank you for sharing that with us. And I want to ask my colleagues on the board now if they have any questions. If you want to come back here, I'll take a wander. So do any of the board members have questions?
Thank you for your presentation. For the Safe Supply program, could you give us an idea of the distribution by age group?
Sorry, are you safe supply or harm reduction supplies?
Harm reductions. Anyways, providing not naloxone, but providing drugs to drugs to replace the
Oh, okay.
advance.
Yeah, so that's not part of something that the suit team does. That's Charmaine might have more information about that piece.
Thanks for the question, Ron. So the program hasn't started yet. So it hasn't been decided on who is in those programs yet, but there'll be, as the program rolls out, there'll be a lot of evaluation, and we'll have that data as it happens. But right now it hasn't started yet for the safe supply, prescribed safe supply.
I could throw in there,
You don't
though,
have to.
one thing that SUIT does do very well is connect people of all age groups to primary care providers for, OAT therapy and medication prescriptions.
That's okay. Thank you for your presentation, and thank you for the work that you're doing. It really makes a difference. You're describing really great wraparound services. I'm just wondering, from your perspective, is there still something that's missing or something that could be enhanced or added that would make more of a difference?
It's a great question. Housing. Access to housing and low barrier housing, and that really trauma-informed cultural approach, cultural sensitive approaches to what meeting people where they're at looks like in a stable, to help stabilize them in that kind of environment.
I would add maybe more, and that's my bias of my working background with withdrawal management, but I would say more access to treatment and supportive recovery and sober housing.
Thank you, and thank you very much for your presentation. When you talked about the people's distrust, it strikes me that for a service like yours, the longer that you go, the curve of getting to know people and being effective probably rises over time. So I want to ask two questions. When do you think is when you start a service like this, how many years does it take before you think you're working at an optimal level? And do you think that your service is being replicated at other places in the province? And are they in a similar time frame that we could see maximum results?
Leanne may have more to speak about that, but I can certainly say from the relationship and trust building piece that one of the staff did say to me that we know we've made bridges and relationships with people when they're calling us out by name on the street, and you know you've built that relationship and developed trust, and optimally the team has grown. When I started last year in February, there were 4 people on the team, and we have 11 full-time staff now.
Yeah, I think all I can say to that is it's a very individual journey, and trust is established, I think, by consistency. And part of the reason we have the orange jackets actually is because the SUIT team and other outreach teams throughout the island are wearing them. And a lot of our folks don't necessarily stay in one community, and we really wanted people to identify quickly, orange jacket means I can maybe get support, really low barrier, and it's identifiable. I don't know about optimum reach because the population's growing, and part of that is the housing and people not being able to afford where they're at. And so we're seeing more people come to our communities who are unhoused and needing that support.
Great. Thank you so much. I think this is working, is it? Yeah. Okay, great. Thank you so much, and thank you for demonstrating the orange jacket. I'm sure that's an important aspect of being recognized and developing trust, and thank you to my for your questions. They were excellent. Thank you. Thanks so much. Well, I think this might be the last time I stand up here because, oops, I don't need this now. As a board and an organization, we really value our community partnerships. So thank you for coming today. And now it's our turn to allow you to ask some questions. And I may have misspoke myself earlier on, but we're going to try and mix up the people that are online and the people that are here in the room. We do have a 3:30 stop, so we'll get to as many questions as we possibly can. And if you don't get the opportunity to ask questions before our time is up, then we will make sure that those answers come to you later. So we're going to intersperse the room and the online questions. Have I got that right, Mike? Perfect. Okay, great. So I'm going to start actually with one from online. And this question comes from Carolyn. Carolyn asks, why are so many folks who are double and triple vaccinated still contracting COVID? Charmaine.
That's a great question.
Yeah, I think it's on. You have to hold it.
That's a great question, and I love it. So I'm going to tell you why, and that's because the virus has changed, but the vaccine continues to be effective against serious outcomes. So as the virus has mutated, we have seen it's become more transmissible, less virulent. When we first had the vaccine over a year ago, year plus, we saw a lot of protection against symptomatic infection. So that means fever, cough, any symptoms of COVID, as well as serious outcomes. The purpose of vaccine is to, for all of our vaccines, we have many, the purpose of vaccine is to reduce or stop serious outcomes, not to stop symptomatic infections. So when we first had the vaccine, we had a strain of the virus that was not as easily transmitted and caused a lot of serious outcomes, and we saw a significant proportion of people vaccinated not get COVID at all. So they had no symptoms, and the people who were getting really sick were the unvaccinated population. Then as the virus changed, we saw that it became more and more transmissible, easier to get, more people had symptoms, even though you were vaccinated. But that population still was not, the vaccinated population is still not getting the serious outcomes. So the point of the vaccine, the purpose of the vaccine to prevent serious outcomes is still protective against serious outcomes, even though the virus has changed. So that's why don't worry about the symptomatic infection. Manage yourself based on your symptoms, even though you're vaccinated. Thank goodness you have symptoms, because that means it could have been far worse for you if you weren't. As we are going to see changes in the vaccine as we go forward, the vaccine will include other variants as time goes on. So there's a lot more information that we need to receive as time goes on which what's in the vaccines and when to get the vaccine. But we might even see a new vaccine, an updated vaccine this fall that'll include Omicron. So that's why I want to encourage people that just because you're vaccinated and you have a symptomatic infection doesn't mean the vaccine didn't do its job. The vaccine did do its job, so keep getting the jab. That's great.
Thank you. So are there questions from the floor? There's a gentleman right at the back in a plaid shirt. Hi, Andy. How are you? We missed you this morning.
Yes, you did. And first of all, I just want to say thank you to you, Leah, and I know that, and Max, for being here and putting on this forum. I can tell you, after 35 years working in healthcare, starting at the original St. Joseph's Hospital in Victoria, and then being up here, there is still a need for those central services, which is why I was not at the meeting last night or here this morning as I was down in Victoria. So made it back in time. But I want to talk about the need and the challenges that we have here in Campbell River. Last night's public hearing, we heard from Jim Costain. We heard from, I just had an email 30 minutes ago while sitting here from Chris Demford from Berwick Homes, that they are really, really challenged. And Patty at Tye Apartments just really, really challenging times. Now, hearing what we just did about, you know, the Sobering Assessment Center, AVI, the Moose, the Suits, the Rose Bowl, the Heritage River Inn, Quaxum Place, the facility up on Dogwood, Quaxum Place, and Quasa Place, I should say. They're all little bits of help, but what's happening in between those services is way beyond what Mr. Whipper here in his bylaw enforcement and our contracted bylaw and Jeff Preston and our RCMP can handle. And what is really, really needed is, sure, housing is going to be a help. And really pleased that we've signed the partnership earlier this week with Turning Point for expansion of the second chance sobering assessment facility that will be for both men and women in this community. So that's another great piece, but it's going to take 18 to 24 months to get there. What we really need, and we keep hammering on the Minister for Mental Health and Addictions, is those mental health and addiction facilities for those that need 24-hour help beyond the in-term services that are currently being offered. When can we expect that, or what can we do to help Island Health pressure the government to follow through on that responsibility? The services we had, they were cut. We went to a different model. It's very evident that model isn't working. And despite all of the heroic efforts that people are trying to do every hour of the day, it's not enough. Thank you.
Thank you. Do you want to answer that, Kathy? Thanks.
Sure. And thank you for the question, Mayor Adams. And I just want to start by saying, despite, exactly as you said, the many, many services and supports that are in place for those who have complex mental health needs, complex substance use needs, and Elizabeth said it so well, poverty, adverse childhood events. There are so many kind of causes, if you will, or root causes here. The solutions have to be multiple as well. And so I would say the fragmentation of the many services that are in place don't make it necessarily easy for us to have some kind of a coordinated response. I'm hearing you speak to the need for complex care housing, which I think many of you maybe in the room know that the Mental Health Ministry of Mental Health and Addictions has made some announcements of investments for complex care housing for this population. The only one so far, unless something's changed that I'm not aware of, has been in Victoria, which is in partnership with BC Housing. So I think the approach to date has been to wrap around these complex care services in already existing facilities or newly built facilities, because there's no capital to go along with the investments. It's really right now at an operating level. So the question would be, where are those facilities, and where are they already existing, or where are they to be built, that we can wrap around a proposal in collaboration to offer that as another alternate location. And I know our team here, Sheila Ledbetter is here as our Executive Director for Mental Health Substance Use for the Centre North Island. Sheila, I don't know if you have more information on complex care housing that you'd like to offer.
Well, it just so happened that a group of us went over to Vancouver and Rain City's in Surrey, and they have 130 low barrier beds in a building where 30 of them are for complex care clients. We learned a lot from them. Our heads are exploding. And so as we get the funds in each of our communities, it's learning from people that the lessons learned. And the other thing is we know that even those that are in low barrier housing right now, they're at risk of eviction because of their behaviors. These are the things that our outreach teams can mitigate right now, and not wait for, and not have more people out on the street because they're being evicted. But, you know, it really does come down to getting that funding, working with our operators, supporting them so that people can be successful in having shelter.
Okay, Andy? Great, thank you. So now I want to come back to the online questions. And we have a question from Tanya, who asks, how long does a patient at North Island Hospital presenting with a mental health / psychiatric issue wait on average to be seen by a psychiatrist when referred, or 2, wait to access an inpatient psychiatric bed? And I understand, Dieter, that you are going to answer this question. Thank you.
Thank you. So at the Campbell River Hospital at the moment, we do have access to 2 psychiatrists that visit the site 3 times per week. So depending on the day when a patient presents, it could be as little as a few hours to see a psychiatrist, or approximately 2 days. In terms of accessing a mental health bed, that does depend on availability across the island and elsewhere. So I don't have a concrete number to give you, but I would say on average less than a week.
Great, thank you. All right, so let's go back to the audience again. So the lady in the front here, I'm sorry I don't know your name.
My name's Ann Livingston.
Hi, Ann.
I came from Nanaimo today because you're the health board for Nanaimo too, and I didn't want to wait a year for you to come to Nanaimo. I'm not sure how many meetings you have a year, but I'm working with a group called the Nanaimo Area Network of Drug Users, and we meant to start a drug user group, which is to provide advocacy, education, and support, which is like a club or a, it's membership driven. Yep. I mean, it's like a support group for people who haven't been able to stop using drugs. And we're completely overwhelmed because there's nothing in Nanaimo, and we are in an outdoor lot. So we get caught in this sort of hassle, because it would appear that the municipality of Nanaimo is hostile to this kind of thing. And it would appear, so my question, I guess, is once the funding has come forward for something like a smoke, people who smoke, and I don't know if you're all aware, it's really the thing. I mean, the needles just stay stacked up. And everything's smoked. It's like 75–80% of people are smoking. And that's what's killing them as well. They just go down like a sack of potatoes, just bam, they hit the so I'm just saying, so that's my question, is this kind of caught betweenness between the Ministry of Mental Health and Addictions makes available funding. Often they go through a whole request for proposal process, which I believe has taken place in Nanaimo for something like a smoke site. And then we get this really long delay where we count dead bodies, which just doesn't seem like health care for everyone every time, So I'm a bit frantic. I mean, in the sense of saying what I'm finding is if we're gonna end up in this positions, which we are, within a month, we've got 50 people a day. We'll have 100 people a day next week. I'm just saying. Because when there's nothing, it's really popular. And also, the model for drug user groups is extremely attractive to people who are drug users because it's their place, and they are a member, and they get to vote for the steering committee. So we have a tiny bit of funding we got from the Community Action Initiative, which is associated with Canadian Mental Health. I'm not sure if you're aware of this funding. It goes through the Overdose Emergency Response Center. So despite being funded by the Overdose Emergency Response Center, we feel completely disconnected from anything substantial coming down, even in the way of homeless facilities. You know what I mean? There's just a very large number. Yeah. So we're trying to get bridge funding until the actual smoke site opens, because it is a tricycle going 40 miles an hour and the wheels are rattling. It's $80,000 for a whole year. 36,000 of that goes for the lease and the, internet and the phone. Yeah. And that leaves us with the foxes are in charge of the hen house, I can just tell you. The patients are running the asylum. So it's completely, any kind of funding where one person could be a staff person or any kind of thing. We meet with the allies, but they're all very nervous of us, I think, but they're very kind. And so we're not lacking supplies. We're just mostly, I'm worried as we see ourselves driving off a cliff. And I was hoping that there was someone I could speak to about this, bridging until the real smoke site, the proper one.
Right. Well, I think the person that you need to speak to about it is sitting right beside you, James Hansen. And so I don't know whether, James, you want to do that with Anne when the meeting is concluded. It might be better because it's probably a fairly long answer.
Just here, take my card.
Oh, okay. So thank you for coming here from Nanaimo, and we do get to Nanaimo from time to time. So another question that was submitted in advance is submitted by Lois on behalf of the Citizens for Quality Health Care. And Lois asks, on behalf of the Citizens for Quality Health Care, when can we expect the multiple problems at the Campbell River Hospital lab to be fixed and services and staff to be restored there? Ian, can I ask you to answer that?
Yeah, sure.
Thanks.
Can you hear me? Okay. For those of you I've not had a chance to meet, my name's Ian Thompson. I'm a GP by background, currently Executive Medical Director in Medical Affairs and Island Health, and up until very recently, and Dieter's taking over, providing support for the North Island. A couple of elements to that question, and I think one of the most important to realize is that healthcare has become increasingly specialized over the years, and you know, medicine as part of that. And so when I started in practice 30 years ago, I sutured dogs and pulled teeth and a number of things that I don't think there are many GPs doing currently. And I guess the analogy in lab medicine and pathology, the docs who look after lab medicine, is that historically we tended to have general pathologists. Over time, we've realized that someone who looks at 1,000 skin biopsies a year does a better job of picking up a skin cancer than someone who looks at 10. And so, for instance, in this case, we've got a nationally recognized skin pathologist based in Victoria, and he's looking at all the challenging skin biopsy cases from the island. So part of the answer is, as we bring in more specialized services to provide the best possible care to the citizens of Vancouver Island, there is a degree of specialization that happens and centralization that happens. General pathology is not going anywhere. There's still a full-time general pathologist here in Campbell River. There's a second part-time pathologist who will be starting this year. We've got 3 pathologists in Comox. And so the general pathology piece, like the hematology, the oversight of blood samples, is still done locally, and that'll continue to be the case. And in fact, since 2020, I think the turnaround time's decreased by about 4 hours for those hematology samples. So we're keeping a close eye on turnaround times. We're keeping a close eye on the quality of the analysis. But as I say, the wave of the future is really going to be for specialized services to be concentrated in areas where people have enough volume that they're really focusing their time on that which they're best at. And so that's part of what you're seeing play out. I think that covers it.
Great. Thanks very much, Ian. So we have time for one more question from the floor and one more question from the people who tuned in. So the ladies who are in the red, in the 3rd row, I think that is.
Thank you. Since the overdose prevention site has been functioning at its current location directly across from our business, our team has been exposed to all kinds of public health and safety issues. In essence, our team is expected to clean up the mess left on our property by the OPS users, creating a public health concern for our team members. One example of this is both human excrement and harm reduction supplies. What amount of funding is set aside to help surrounding businesses and residents combat these issues?
Great, thanks very much. So Leslie, are you? Thank you, Leslie. I've been wondering who you are. Leslie, how
Now
is
you
going to
know.
answer that question?
Hi, thank you for your question. And I think I'd just like to start by reassuring you that we hear your concerns and we take these concerns seriously when they come through from any of our providers. I think today we've heard that, you know, these are challenging services to offer. Our outreach teams, we do try and wrap around our providers as well as our clients and community. The sites are visited regularly by the staff here and also in terms of leadership to try and work through these problems as they arise, and I know that there have been ongoing concerns expressed. So that being said, I think there's always work to be done. I don't have a number. I know you've asked for how much money. I said I don't have that number. What has happened this week is there's been a bit of meetings, and we were unable to meet and have that discussion with the city and yourselves today. But we do look forward to doing that with you early next week, and just really want to reassure that the teams are here to, you know, support the work to be done in the best way and to support our clients to be able to live and exist in your communities. And so we'll look forward to finding a way forward, I think, together in the next week. But thank you for coming.
And thank you for answering their question. Thanks, Leslie. So we've had several questions from a few people, and that is, why is it so difficult to see a doctor in Campbell River right now? Why is there such a shortage of doctors? Will more nurse practitioners be hired to help fill this gap in services? And Kathy, I wonder if you'd answer that question.
Thank you, Leah. And that is probably the hardest question. Where did all the people go? It's really hard to answer that question. Why? Why is there a shortage now? I know here in this community in Campbell River prior to the pandemic, everybody else on the island was envious of the fact that there was so much availability of primary care in Campbell River. And then some things happened. And we do know how discouraging it is to lose your family doctor. I know I personally don't have one right now. I did speak in the notes to the work that is being done in collaboration with the Division of Family Practice here in Campbell River in the submission of the Primary Care Network, which is the way the Ministry of Health is funding the development of multidisciplinary teams in a network, so that they're not individual clinics, but they're connected to meet the needs of the population. And here in Campbell River, they've been invited to make a proposal that would meet the needs of 8,000 people. So that's a lot of family doctors and nurse practitioners. I think it boils down to 12 physician contracts and 17 nurse practitioners and other members of the healthcare team. So there is hope ahead. That said, what we're experiencing in, and we're not alone at Island Health, I think every health system in Canada that I know of is experiencing the same thing. We're no longer at a point where money seems to be the limiting factor, it's the availability of the people. So we will have the funding through this collaboration with the PCN, but we really are going to have to work hard at recruiting those people because, as I said earlier, everybody's looking for the same people. Everybody's looking for primary care practitioners. Everyone's looking for nurse practitioners. Everybody's looking for physios and pharmacists and nurses. So the best thing we can do is all of us be recruiters. All of us tell the story that Anne told me today about how proud she is to work here in Campbell River, such a high standard of care for this community, how welcoming people were. She told me about the apartment building that she's living in, that other members of the healthcare team have apartments there. It's just like a little community, a village of Campbell River healthcare workers, and she's really enjoying it. They're not going anywhere. So that we need more Anns. And we need more of those messages of we want people to come work here. And I know personally the best way we can recruit people is to tell them what we're proud of and tell them what's working well. It's really hard to recruit when we talk about what's not working well. So that would be my invitation, is to for all of us to be recruiters so that we can build up that primary care network.
Great. Thanks very much, Kathy. Well, as a governance board, we are accountable to you, the people we serve in communities, and that is why it's so important to provide opportunities like this to hear from you. Thank you to everyone who submitted questions or stood up to ask a question. If we did not get to your question, there will be a few members of the board and Island Health leadership team available for a few minutes after the meeting. Thank you again to Kathy, Dr. Enns, Leanne Combe, and Elizabeth Driver for your presentations, your leadership, your compassion, and your caring. And thank you to everyone who came today and those who tuned in to the live stream. The forum is closed. Thank you for taking the time to join today.